Welcome to our clinical reasoning discussion. As you can see on the title screen, we are exploring a fascinating diagnostic mystery called bones, stones, and clonal clues. We will follow the case of a 78-year-old man presenting with extreme hypercalcemia and renal failure. The text here highlights that clonal clues and lytic lesions provide a compelling yet potentially misleading frame for our diagnosis. We will be using a unique stage clinical reasoning discussion format, leveraging the Santosh Agentic Grand Rounds framework. This means we will simulate the perspectives of a resident, an attending physician, and an expert clinician to unpack the case step by step, moderated by Dr. Anupam, who acts as human in the loop. It is a complex scenario filled with twists, turns, and a few red herrings. Let us dive into the specific focus areas we will tackle during this session. Looking at the two columns displayed here, our learning objectives are split between clinical reasoning and advanced pathology. On the left, we aim to develop a systematic approach to severe hypercalcemia, specifically when levels exceed 14. We will also interpret inappropriately non-suppressed parathyroid hormone in this setting and learn to recognize red herrings in multisystem presentations. Moving to the right column, our pathology goals involve understanding the diagnostic value of a tissue biopsy when clinical syndromes overlap. Finally, we will analyze the complex intersection of metabolic, renal, and neurological manifestations, particularly focusing on coriform movements. These objectives will guide our thinking as we navigate the patient's symptoms. Now, let me explain exactly how our multi-agent simulation will unfold. On this screen, you can see the structure of our multi-agent simulation divided into stages and perspectives. The left panel outlines our 4 key stages, starting with the initial clinical presentation and imaging, followed by the interval history, biochemical clues, and concluding with tissue diagnosis. On the right panel, we define the 3 distinct perspectives our AI agents will take. The resident will focus on initial interpretation and bedside priorities. The consultant will critique the plan and provide Bayesian refinement. Finally, the expert will synthesize the key pivot points to reach a unifying diagnosis. This structured approach ensures we evaluate the evidence from multiple clinical vantage points. Let us begin by reviewing the patient's initial history and physical exam. Notice the clinical history detailed on the left side of this slide. Our patient is a 78-year-old man presenting with hypercalcemia and renal failure. 4 months prior, he was admitted for dyspnea, rib pain, flank pain, and hematuria. His imaging at that time showed stable calcified hilar lymphadenopathy, which had been present for 2 years, alongside a new 1.3 centimeters of pleural nodule. On the right side, the exam details show normal vitals, basilar rails, and a grade 2 out of 6 systolic murmur. He improved with supportive care and was discharged with advice for follow-up imaging and a cystoscopy. With this baseline established, we need to pause and consider our initial diagnostic hypothesis. Taking a look at the questions posed on this screen, we reach our first audience pause. The central question asks what dominates the differential diagnosis at this early stage. The first prompt asks us to weigh whether recurrent hypercalcemia combined with chronic hilar nodes points toward a malignancy or a chronic infection. The second prompt challenges us to consider how the recent onset of right pain and hematuria might reframe those older hilar findings. Finally, we must decide on the most critical next investigation to order. These are the exact questions our simulated medical team must grapple with. Let us see how the resident, consultant, and expert interpret these initial clues. Here we see the initial hypothesis from our 3 clinical perspectives. On the left, the resident prioritizes multiple myeloma, noting the CRAB criteria or renal cell carcinoma. They consider sarcoidosis but felt the calcified node suggested an inactive disease process. In the middle, the consultant firmly states that myeloma is a must-exclude diagnosis demanding immediate labs like parathyroid hormone, vitamin D levels, and serum protein electrophoresis. On the right, the expert offers a slightly different take. They argue that these stable calcified hilar nodes are actually a pivot toward chronic granulomatous disease, though they agree myeloma must be urgently ruled out. Unfortunately, the patient's condition is about to take a concerning turn. As displayed in the symptom and lab panels here, the patient experiences significant clinical deterioration. The left panel lists significant fatigue and recurrent hematuria, but more alarmingly, new neurological signs have emerged, specifically mild cognitive decline and choroiform movements. His current medications include donepezil, tamsulosin, aspirin, and quetiapine. Shifting to the right panel, his labs reveal a severe acute kidney injury with a creatinine of 5.26 and a blood urea nitrogen of 77. We also see marked hypercalcemia at 14.9 milligrams per deciliter, an elevated erythrocyte sedimentation rate of 56 millimeters per hour, and anemia with hemoglobin at 10.5 grams per deciliter. These fresh data points force us to reevaluate our entire diagnostic framework. Looking at the new prompts on the screen, we face another critical audience pause. The main question asks how these new neurological signs fundamentally change our diagnostic puzzle. We have to determine if the coriform movements are merely a metabolic byproduct of his severe uremia and hypercalcemia, or if they represent direct brain involvement. Additionally, the second box asks how the rising inflammatory markers and worsening anemia shift our differential priorities. Finally, we face a major procedural decision whether to biopsy the kidney immediately or wait for the pending myeloma markers to return. We will now turn back to our clinical agents to see how they process this escalating situation. This slide breaks down the refined differential from our team. The resident on the left points out that the crab features calcium, renal, anemia, and bone are incredibly loud right now, suggesting the coriform movements could be metabolic or related to neuromyeloma. In the center, the consultant notes that the elevated sedimentation rate supports an inflammatory or clonal process and recommends planning a renal biopsy. On the far right, the expert is narrowing the focus to a calcitriol mediated process versus myeloma, insisting that the chronic calcified lymphadenopathy remains a major clue rather than an inactive past issue. As we wait on the biopsy, some striking laboratory and radiographic results arrive to complicate matters further. Notice the striking labs and imaging finding detailed on this screen. On the left, the calcium has peaked dangerously at 17.1. The parathyroid hormone is 22 picograms per milliliter, which is inappropriately non-suppressed for that calcium level. We also found an IgM cation component of 0.24 grams per deciliter, and a bone marrow biopsy revealed 7% clonal plasma cells. Over on the right, the imaging is just as provocative. A skeletal survey shows widespread lucent lesions in the skull and legs. Furthermore, an FDGP-80 scan demonstrates marked avidity in the mediastinal and hilar lymphadenopathy, accompanied by an ACE level of 61 units per liter. These conflicting signals require careful interpretation. Reading the questions on this slide, we hit our most challenging audience pause yet. The core dilemma is how to reconcile a parathyroid hormone level of 22 with a massive calcium level of 17. Does this point to concurrent primary hyperparathyroidism? The middle box asks whether finding 7% plasma cells and a small M spike is enough to definitely establish a diagnosis of multiple myeloma, or if it is just a distraction. Lastly, we must determine the true significance of those heavily calcified nodes lighting up on the PET scan. Let us see how our simulated panel synthesizes these highly conflicting clues. The synthesis of these conflicting clues is laid out perfectly here. The resident notes that the inappropriate parathyroid hormone suggests a parathyroid contribution, while the M spike might simply represent monoclonal gammopathy of undetermined significance. The consultant takes a firmer stance, calling the hormone level pathognomonic for autonomous production and recommending a 4D CT of the neck. However, the expert on the right delivers a vital teaching pearl. They emphasize that a mathematically normal hormone level in the face of severe hypercalcemia is actually highly abnormal. They suspect sarcoidosis is driving the calcium and kidney injury, with the IgM clone being purely incidental. To settle this debate, we must look at the actual tissue samples. As you can see on the screen, the tissue confirmation finally gives us the definitive answers we need. The left panel shows the results of the renal biopsy, revealing chronic active tubulointerstitial nephritis alongside poorly formed non-necrotizing granulomas. The right panel details the paratracheal lymph node biopsy, which demonstrates compact, confluent, non-necrotizing granulomas. Crucially, stains for acid-fast bacilli and fungal infections were completely negative. Together, these biopsy results confirm a diagnosis of active sarcoidosis, proving that the calcified nodes were not merely remnants of an old infection after all. With the pathology confirmed, the team must now agree on the final treatment strategy. Looking at the final reasoning stage, the team reaches a consensus based on the pathology. The resident acknowledges that sarcoidosis is the primary driver and recommends starting steroids immediately. The consultant agrees, suggesting an initiation of zero point 0.5 to 1 milligram per kilogram of prednisone while monitoring the calcium and creatinine response. They do note that the inappropriate parathyroid hormone still needs eventual clarification. The expert brilliantly ties it all together on the right, diagnosing systemic sarcoidosis with renal involvement and highly likely neurosarcoidosis causing the coliform movements. They confidently label the IgM clone as a coexisting, distracting condition. This brings us to the formal conclusion of our diagnostic mystery. The text displayed here presents our final ununifying diagnosis. The patient suffered from multisystem sarcoidosis, presenting with granulomatous tubulointerstitial nephritis, calcitriol-mediated severe hypercalcemia, and neurosarcoidosis. The clinical response at the bottom of the slide validates this conclusion beautifully. After initiating steroid therapy, the patient experienced a dramatic stabilization of his renal function, with his creatinine dropping down to 1.6. Even more remarkably, the treatment led to the complete resolution of his choriform movements, proving they were indeed neurological manifestations of sarcoidosis rather than just metabolic encephalopathy. It is helpful to review exactly how our diagnostic focus shifted over time to reach this point. This timeline illustrates the fascinating evolution of our clinical reasoning across the 4 stages. In stage 1, the hilar lymphadenopathy and hypercalcemia had us debating between sarcoidosis and malignancy. By stage 2, the discovery of the IgM protein and lytic lesions caused our suspicion for multiple myeloma to peak. However, moving into stage 3, the combination of an inappropriate parathyroid hormone level, petty nodes, and an elevated ACE level forced a crucial pivot back towards sarcoidosis. Finally, in stage 4, the tissue biopsies provided absolute confirmation of granulomatous disease. This journey highlights some vital clinical pearls that we should carry forward into our daily practice. Looking at the take-home messages provided on this final screen, we have several critical clinical pearls. First, remember the clinical logic that in cases of severe hypercalcemia, a numerically normal parathyroid hormone is actually pathologically inappropriate. Second, we must learn to ignore red herrings. Monoclonal gammopathy and lytic lesions in the elderly can be major distractors from the true underlying disease. Regarding sarcoid specifics, keep in mind that this condition can cause severe acute kidney injury directly through granulomatous interstitial nephritis, not just secondary to hypercalcemia. Finally, recognize that choriform movements in a sarcoidosis patient strongly point toward neurosarcoidosis.
Always pursue tissue confirmation when multi-system presentations offer conflicting clues to ensure the correct life-saving diagnosis is made.